Hello, and welcome to another lecture. My name is Carlos Brian Francia, and today we're going to be learning about the coagulation cascade. So what happens when you get a cut? Well, when you get a cut, you have injured vessels. So your little vessels inside the body get torn, and they start releasing product, such as erythrocytes, white blood cells, platelets, and your body doesn't like to be injured, and so it wants to cover that injury up. But how do we do that? Well, when we have an injury, let's say we have this little tear right there, it comes in contact with the outside world, and when the tissue is exposed to the plasma in the blood, it starts to stick together. So if you get a cut right now, your skin is going to come in contact with the plasma inside your blood and is going to have a reaction in which it starts to stick together. So first, we want to cut off the circulation to this area. We want to reduce it. And this is called a vascular spasm. And what this does is that it's going to decrease the blood flow to this area. If we decrease the blood flow, we decrease the amount of blood lost. Now here, we're going to have little platelets. This is purple. And right here, these platelets are going to meet at this area. And they're going to try to stabilize this area. So now you kind of see these platelets sticking together. And they start to plug up this area. Right here we have the basic formation of a temporary band-aid. So this is like a temporary band-aid. And we are forming the platelet plug. Now there's a certain glycoprotein. So we have a glycoprotein that helps to stabilize this platelet plug. And this is called the von Willebrand. It's pronounced Willebrand factor. Is a von Willebrand factor. And if you have a deficiency in this glycoprotein, well, it's very difficult for your body to form these plugs, and you will keep on bleeding. It's very dangerous. So a von Willebrand factor deficiency would lead to chronic blood loss. So now let's move over to this larger portion right there. With the platelet plug formation, you have a decrease in blood loss, and this little plug is being stabilized by the glycoprotein von Willebrand. But you also have to keep adding thrombocytes, which are the little platelets. When these thrombocytes meet up at this location right here, they start to release little signals. And this guy starts to release chemicals. And really, there are three chemicals. First, we have adenosine diphosphate. And all adenosine diphosphate does is that it helps these little thrombocytes, these little platelets, stick together. So they start to stick together. So now we have more thrombocytes, and they start to stick together with the usage of adenosine diphosphate. It's very similar to adenosine triphosphate, except there's only two phosphate groups. So we have to sticks, thrombo, together. Now, thrombocytes can also release serotonin. And what serotonin does is that it's going to contribute to the constriction of the vasculature. So these, let's say, veins or capillaries or whatever we damaged, serotonin will help them to contract and reduce blood flow. So this also helps to reduce blood flow. So this is vasoconstriction. Okay. And the last one we have are two subtypes. So we have prostaglandins, or phospholipids, lipids. And what these guys do is that they also contribute to vasoconstriction. But also, these guys right here, when we learn about the coagulation cascade, they will help to activate certain factors. So they also activate and activates coagulation factors. The reason why we want to form this platelet plug is because it buys us some time to really form a stronger band-aid, I would say. So this is just a temporary formation, but the coagulation cascade allows us to make a stronger material, and the end product for the coagulation cascade is actually fibrin, which is fibrin right there. So it's going to help secure the area, and it's a lot stronger than the platelet plug. And the fibrin is the end product for the extrinsic and the intrinsic coagulation cascade. So you could say pathways. But now let's actually learn about the anticoagulation cascade. And let's make it fun. Let's say that you have an exam and you have to know about these pathways and the order in which the factors go through. So assuming that you are in a rush, here we go. So the extrinsic, well, guess what? For the extrinsic, that means that we have an external damage. So let's say that you got cut on your arm. This is the extrinsic pathway. It's the way the body heals. So for this one, you're going to do factors 3, factor 7, factor 10, factor 5, factor 2, factor 1. How do you memorize this? Well, guess what? 3 plus 7 is 10, right there. You take 10, you divide it by 5, what do you get? You get 2. So 10 divided by 5 is equal to 2. Well, what happens if you take 2 and you divide it by 2? Well, you get 1. So that's the extrinsic anticoagulation cascade. If you want it in Roman numerals because you're extra, well, guess what? It's just this guy right here. You have 5, 2, 3, that's 7. You got 10, you have 5, you have 2, you have 1. What if we want to talk about the intrinsic pathway? So if we have the intrinsic, what is this? It's when the body has an injury that is inside of the body. So for instance, maybe a broken capillary or a broken vein. We have to fix it inside our body, and it's a lot more complicated and it has more factors. But if you're in a rush, well, we start counting down from 12. We have 12, we have 11, we're going to skip 10, we're going to do 9 and 8, and then, hey, there's something that is kind of familiar. We have 10, 5, 2, 1. So we're going to start counting down 12, 11, skip 10, 9, 8, and then 10. What if we divide 10 by 5? We get 2. If I divide 2 by 2, we get 1. So notice that we have kind of like a similarity right here. But we're going to write this in Roman numerals. So we're going to do this right here. We have X, I, X, I. No, and then we have the 1, X, and then V, 1, 2, 3. Then we have X, 5, 2, 1. So notice that there's kind of a similarity between this guy right here and these guys. So factor 10 is kind of like the branching point in which both the intrinsic and extrinsic cascades meet together. And specifically, this kind of brings us to the common pathway. And the common pathway is always going to result in the formation of fibrin. And what the common pathway is just 5, 2, and 1, where 1 generates fibrin. And that's all you need to know to learn about anticoagulation cascades. And that's the crash course. However, let's actually learn their names and what they do and how to remember them. If you have an exam next week, hey, keep watching. So let's say that I have a damage to the exterior of the body, so the skin. Well, we can kind of see the similarities. Here's my skin, and now I have damage. So there's a hole in the wall. Who made that hole in the wall? It was actually my 3-year-old. Oh my gosh. Can't believe he did that. Well, here we're going to have to fill this hole up with material. And the material that we're going to be using, is actually called factor 3. So that's why they're the 3-year-olds. And factor 3, that is called thrombo, like thromboplasm, like thrombocyte, thromboplastin. So when you own a home, you're going to have to fix the walls eventually, and that's called plaster. And that's the material that we use. That's the gray material right here. So we're going to be plastering the thrombocytes with factor 3. So factor 3 is just going to be called F. So thromboplastin. However, we're going to need a worker to do this because we can't do it ourselves. So we need somebody to do this for us. And the person that we use is called factor 10. So this is Mr. Stuart Prower. And he's really handsome. He's a baddie. He knows he a 10. And this is factor 10. So Mr. Stuart Prower is going to use thromboplastin to plaster this hole in the wall. However, like most people, he doesn't do this for free. We're going to need to pay him. We're going to need to activate him. So instead, we're going to be using calcium. However, Mr. Stuart Prower lives in America and he doesn't like calcium as money. So we're going to have to convert this calcium into something that he likes, American dollars. So how do I get calcium to be converted into American dollars? Well, I'm not a pro, but I need to convert this. So I need a pro converter. So instead, I'm going to be using pro convertin. And that is actually factor number 7. And hey, 7's pretty lucky. And this is a guy's payday. So it's Mr. Stuart Prower's lucky day because he gets paid. And so to summarize, we have a hole in the wall. We're going to be using plaster. That's thromboplastin. That's factor 3. Factor 3 is going to be connecting with proconvertin because it's going to convert the calcium and the thromboplastin to activate Mr. Stuart Prower. He's a baddie. He knows he a 10. So now after Stuart Prower is activated, he's going to use the common pathway of 5, 2, and 1 to close this hole in the wall. But right now, we're just focusing on the extrinsic pathway, and we can focus on the common pathway later. But that's the summary of the extrinsic pathway. Now, before I move on to the extrinsic pathway, I just want to mention that factor 3 is often considered the tissue factor. You'll often see that in textbooks. And you're probably wondering, hey, Brian, I noticed that when you were talking about factors, you didn't mention factor 4. Well, factor 4 is actually calcium. So calcium is just constantly within the coagulation cascade. So it's going to be present in the intrinsic pathway, it's going to be present inside the intrinsic pathway, and it's going to be helping those factors to be activated. So throughout the entire cascade, no matter if you're in the extrinsic or intrinsic, you will always have calcium. So you need calcium for coagulation. You also need vitamin K. And a lot of these factors that you see here, the little cheat codes, they're derived from liver products. So they're made in the liver, except for number 3 and 8. So 8 is because you ate something, it comes from your diet. And of course, factor 4, which is calcium, is not made in the liver. So factor 3, 8, and 4 are not made in the liver. but for the most part you are working with factors that are created from the liver. Here we have the intrinsic pathway. And it's a lot more complicated. So first we're going to work with a detective. Now this is Detective Hageman. It's actually Detective Columbo. I like Columbo. I watch it with my dad all the time. It's a great show. You should watch it. But Detective Hageman works for the police, and so he is 12. He's actually 12. F12. Factor 12. And Detective Hageman is always suspicious. He notices a hole in the wall, and he is activated by prostaglandins. So he could prosecute prostaglandins and also phospholipids. So that's kind of like the whole thing that sets it off. So Detective Hageman, F12, is going to look at this hole in the wall. So this is also XII. Well, what happens next? What happens next is that Detective Hageman, F12, factor 12, is going to be contacting 11. So this is factor 11. Another name for factor 11 is anti-hemolytic. C. A deficiency in anti-hemolytic C is going to cause a person to bleed. And this is pretty rare. It leads to hemophilia type C. Another name for anti-hemolytic factor C is going to be thromboplasmin antecedent. So thromboplasmin antecedent. Well, antecedent in this case means that we come before this name. So factor 11 comes before another factor, and that next factor is called thromboplasmin. But who is 11 calling? Who is factor 11 calling? Well, factor 11, antihemolytic C, is going to be calling her sisters. And her sisters are twins. And they do everything together. They always brag about how they went to Harvard and, oh, they're so better than 11. Well, she's sick of it. However, they are the ones to call when you need help because they're really smart because they went to Harvard. So now we're going to be calling factors 9 and factor 8. So I don't like Roman numerals, but that's how you write it. So factor 9 and 8, they are a team. And their names are antihemolytic, so we're just going to call this antihemo type B. And we also have antihemo type A. So whenever you have a factor 8 deficiency or factor 9 deficiency, that's what you have a deficiency in. It's actually the deficiency of these coagulation factors. So this gives rise to hemophilia type A, this gives rise to hemophilia type B. Hemophilia type A is more common within people, hemophiliacs, people who bleed a lot because they have a deficiency in type 8. And again, right here, since factor 11 is called thromboplasmin antecedent, we're going to call factor 9 thromboplasmin. But why is antihemolytic C calling antihemolytic B and antihemolytic A? Well, it's because they're daddy's favorite, because they went to Harvard. But who's the dad? It's actually Stuart Prower. He a baddie, he a 10. And because they're the father's favorite, he's going to do everything he can to help them out. And so they're going to tell their dad, hey, there's a hole in the vein. Can you fill it up? And he's like, okay. So now we're dealing with Mr. Stuart Prower. So we have factor 10, which is Stuart Prower. That's actually the name, factor 10, Stuart Prower. And the reason why antihemolytic B is paired with antihemolytic A is because they form a coenzyme. So they form a coenzyme, and that coenzyme activates Stuart Prower. And that's pretty much the last section of the intrinsic pathway. So to recap, you have Detective Hageman, F12, contacting the factor 11 antihemolytic C, also known as thromboplasmin antecedent, and she's going to call her sisters, which are twins, and they went to some sort of college, I don't know. But the twins are called antihemolytic B and antihemolytic A. Antihemolytic B is also called thromboplasmin because it is formed after the thromboplasmin antecedent. They form together. You can see they're holding hands right there. They're holding hands, and that forms the coenzyme. And together they go to their dad, Mr. Stuart Prower. He a baddie, he know he a 10. And Mr. Stuart Prower is going to be working on the hole in the wall being a vein inside the body. And now we'll be talking about the common pathway. So both the intrinsic and the extrinsic pathway always merge into the common pathway. And the common pathway is when Stuart Prower, which is also factor 10, he's going to be filling this hole in the wall, and he's going to make it smooth, and he's going to heal it over. So this is the end product. So what he's doing is that he's going to be accelerating at his job. So he's a professional who works really fast and efficiently. And the way he does this is that he uses a factor called factor 5 or proacelerin. And that speeds up how fast Mr. Stuart Prower works. So he uses factor 5 proacelerin. So now we're looking at this section right there, proacelerin. But now we have to work with some new material, and the material that we're working with is called factor 2. So we have factor 2, and this guy right here is called pro, that means before, thrombin. So he's a pro, he works with thrombin, but we have to convert this thrombin from prothrombin. So to get from here, we have to convert prothrombin into thrombin. We use an enzyme called prothrombin ACE. And we know that ACE right here is just an enzyme. So as Mr. Stuart Prower lays down the plaster on the wall, we can call this prothrombin. It hardens and it converts into thrombin using the prothrombinase enzyme. After that, we're going to start using another factor. So thrombin activates another factor, and that's going to be called factor 1, which is actually fibrinogen. And guess what? Gen means to generate, so we can say generate or create fibrin. And that's the ultimate end product of both the extrinsic pathway and the intrinsic pathway. So when they all branch into the common pathway, Mr. Stuart Prower gets to work. He's going to use factor 5 to accelerate, and that's called proacelerin. He's going to be laying down plaster, and that's called prothrombin. Over time it hardens because it converts into thrombin, which is still factor 2. But to get from prothrombin to thrombin, we use prothrombinase, which is an enzyme. And then thrombin is going to activate factor 1 called fibrinogen. That's going to generate fibrin. And fibrin is going to kind of stick around in these holes and seal it up very nicely. And that's the ultimate end product of all the pathways, either extrinsic or intrinsic. You always want to generate fibrin. And you also don't want this to break apart easily. You don't want fibrin to break apart easily because all your hard work is going to go to waste. And so you need some super glue to stabilize this area. And for that factor, we're going to be using factor 13. So we're going to be using factor 13. 1, 2, 3. So that is factor 13. And this name is just called fibrin stabilizing factor. Because wouldn't it be unlucky if this fibrin was not stable and it just broke apart? So this is unlucky 13. So factor 13 is going to kind of super glue this fibrin, factor 1, so it stays together and it doesn't break apart easily, because if it did break apart, we would be very unlucky. So unlucky number 13, fibrin stabilizing factor. However, there does come a time when the body needs to remove the fibrin. So after the skin fully heals, we need to get rid of this fibrin because we don't want any blood clots circulating in the system. So we got to get rid of this. And that process is actually called fibrinolysis. So it is the cutting of the fibrin. So fibrinolysis. And for right now, all we need to know is that we're going to be using something called plasminogen. And remember, gen means to generate. So we're going to generate what? We're going to generate plasmin. And the plasmin is going to go over here and is going to kind of start breaking apart the fibrin. So that's all plasmin is going to be doing. It's going to break apart this fibrin so that we don't have any potential blood clots forming inside our body, because eventually we got to get rid of them. And really, that's the end of the coagulation cascade. But before I go, I just want to explain why we want to have thrombin inactivated in the body. So notice that we went from prothrombin into thrombin. You're probably asking yourself, well, why isn't thrombin just naturally circulating? Why does it have to be activated? Well, thrombin is going to cause this coagulation. And if thrombin was always activated, you would spontaneously have little bits of coagulation in your body. And that would cause an embolism, and it could cause a stroke or a heart attack or anything severe. So you don't want thrombin just being activated all the time. You need to have something to flip it on and off. And in medicine, we often want to stop this coagulation. We want to have anticoagulants. And for instance, antithrombin is going to oppose factor 10. So antithrombin is going to oppose factor 10, and factor 10 can no longer cause the, filling up of the holes. So antithrombin opposes factor 10, and that's actually a known anticoagulant. Heparin, which is often given to patients. For instance, if you have a Metaport and you flush it, you use heparin as an anticoagulant so the blood doesn't harden and cause harm to the patient. Heparin also opposes the anticoagulant cascade. So when heparin reacts with antithrombin, it's going to inhibit both factor 10 and factor 2. So that's why we call it antithrombin, and we use heparin. And fun fact, heparin can be derived from a pig liver. So whenever a pig is being slaughtered, they would get the livers and kind of extract heparin from it. And a lot of the heparin that we use in medicine is manufactured from pig liver. Let's talk about one of the most famous antiplatelet drugs, and that is aspirin. So when we talk about aspirin, that is going to be antiplatelet. And when you think of platelets, you should be thinking about this guy right here. This is thromboxane. And thromboxane allows the platelets to stick together. So it's going to cause vasoconstriction, and is going to make the platelets sticky. So when those platelets touch each other, they're going to stick together and form a clot. So it's going to make platelets stick. And so if we can block thromboxane, we can prevent vasoconstriction, and we can prevent the platelets from sticking, and that prevents the coagulation from happening. So how do we do that? We use aspirin so that we can block this guy, and this guy is called cyclooxygenase. But why do we want to block cyclooxygenase? Well, TXA, thromboxane, is a prostaglandin, and prostaglandin is created through this cyclooxygenase reaction. Within the membrane of the cell, phospholipase A, which is another enzyme, is going to start breaking down these phospholipids. And so now these phospholipids are going to create something called arachidonic acid. You don't really have to memorize this whole process, but you just have to realize that phospholipase A, too, is going to be interacting with these phospholipids. They convert the phospholipids into arachidonic acid, and now cyclooxygenase is going to convert this arachidonic acid into prostaglandin. Now there's a whole family of prostaglandins, and you don't have to memorize all the prostaglandins, but you do have to know three main characters, and that is thromboxane. You're going to have to know that this is prostaglandin E2, so that is prostaglandin E2. And this guy right here is prostacyclin. And we're going to talk about these guys in detail in the next few minutes. And so when we use aspirin, we're going to start blocking the cyclooxygenase reaction. So this aspirin blocks the COX, and if you block the cyclooxygenase reaction, you no longer have thromboxane, you don't have prostaglandin E2, and you don't have prostacyclin. And if you don't have these guys, it's harder for the blood to start clotting, or it's harder for the platelets to start sticking together, and that's why we use aspirin. But now we have to figure out why aspirin does it in the first place. How does aspirin block cyclooxygenase from doing the reaction? I know that this picture may seem a little bit complicated, but it's really not. Here we have cyclooxygenase 1, and there are actually two of them. So there's cyclooxygenase number 2. We're going to talk about him in a few minutes. But what happens here is that arachidonic acid is going to go into the cyclooxygenase enzyme, is going to bind to this catalytic site, and what happens now is that arachidonic acid is going to convert into these prostaglandins. So that is a prostaglandin. So here we are, arachidonic acid, it goes into the cyclooxygenase, it touches this little catalytic site, it converts into prostaglandins, and one of these prostaglandins is called thromboxane A2. And thromboxane A2 is going to activate the platelets, and that makes the platelets sticky, and that causes the formation of clots. And the way that acetylsalicylic acid operates, here's aspirin, is that this acetyl group right here is going to stick to the binding site. So this guy right here, he's going to be blocking the binding site. Now when arachidonic acid tries to go to the binding site, it's already occupied. It can't touch it because it already has an acetyl group. And now arachidonic acid can no longer convert into prostaglandin. Therefore, we can say that this binding site has been acetylated. So we have the acetylation of this binding site. And yeah, I mean, you can realize that it's a serine group, but you don't have to memorize that. You just have to know that the acetyl group of aspirin, it goes into this catalytic site, it blocks it, and we no longer have the ability to bind arachidonic acid into this area. If arachidonic acid can no longer bind, it can no longer become a prostaglandin. And if you can no longer become a prostaglandin, you can no longer create thromboxane A2, which creates platelets. Like I said before, we have two types of cyclooxygenases. We have cyclooxygenase 1 and cyclooxygenase 2. And both of these guys are going to create the big three. So the big three are going to be thromboxane. We have thromboxane. We also have prostacyclin, PGI2, and prostaglandin E2. So we have PGE2. So they're going to make the big three. However, if we have medication that can block specifically COX-1 or COX-2, we're going to have different effects. So for instance, aspirin, when we're dealing with aspirin, this guy right here has a strong preference for the blocking of cyclooxygenase number 1. And if we block cyclooxygenase number 1, you get rid of the majority of thromboxane, and you also get rid of the majority of prostaglandin. So COX-1 and COX-2, while they make the same families, they have a preference for the creation of one or the other. So this one right here is going to be number 1. He has a preference for this creation. You also have a preference for this guy. So thromboxane and prostaglandin E2, they are created by both COX-1 and 2, but COX-1 likes to create these guys. They like to create thromboxane and prostaglandin. Now COX-2, if we block it, let's say with the drug Celebrex, so for instance a famous one is Celebrex, Celebrex, that is really preferencing the inhibition of cyclooxygenase number 2. And if we block him, we block a majority of prostacyclin. And actually, this is not an O, that is an E. So that is an E right there. Celebrex. When we talk about non-steroidal anti-inflammatory drugs, we're talking about medication or over-the-counter drugs that can inhibit cyclooxygenase 1 or cyclooxygenase 2. And the reason why we call them anti-inflammatory is because these guys are going to make prostaglandins, and prostaglandins signal for inflammation. For the most part. So some prostaglandins are going to signal for the body to increase the heat, and that causes inflammation in the area that is infected, let's say. So let's say that you have a fever. Well, your body is trying to get rid of some pathogens, and it's increasing the amount of prostaglandin creation, and the prostaglandins are going to signal for inflammation in the attempt that we get rid of the pathogen because it's too hot for the pathogen to live in. And so if we can block these cyclooxygenases with NSAIDs, we can reduce the fever. So that's why back in the old days, like in the 1930s or 20s, people were taking aspirin to reduce their fever. Well, when we talk about NSAIDs, we have a plethora of NSAIDs, and each one of them have a preference for the enzymes. For instance, Toradol, that's the brand name for ketorolac. So ketorolac is going to be prescribed in the hospital. It's either given in IV or in oral form, but it has a strong preference for the blocking of cyclooxygenase. But we know that cyclooxygenase number 1 has a preference for the creation of thromboxane, and so if we give Toradol, also known as ketorolac, to a patient, we have to acknowledge that this is also going to thin their blood. Let's say that this patient is also taking blood thinners like Plavix, or they're taking warfarin, which is Coumadin. Then we have to be careful. We have to say, hey, you're already taking warfarin or Coumadin. I don't want to give you Toradol because that's going to thin your blood too much. So we have to be very careful when we're giving Toradol to patients because it has a high preference for COX-1. On the other side of the spectrum, you have Celebrex, and Celebrex is given in capsules. And specifically, I spelled it wrong, is given in doses of 100 milligrams and also 200 milligrams. So it's very powerful and you don't give too much of it. But Celebrex has a preference for the reaction or for the blocking of cyclooxygenase number 2. And therefore, if we use Celebrex, we're mainly going to be inhibiting the prostaglandin. So it's very tricky to say it, but that's what you're inhibiting when you use Celebrex. And then if you look in the middle of this little spectrum, you have your over-the-counter drugs. So you have your Aleve, your Advil, your Midol, your Motrin. So these guys right here, the Advil, Midol, and Motrin, they're really just ibuprofen. But naproxen is Aleve, and they can go either way. They can they bind equally for the most part to cyclooxygenase number 1 and cyclooxygenase number 2. So when you use these guys, they're going to have an effect on all of the prostaglandins. So some of them they're gonna block thromboxane, some of them are gonna block prostaglandin E2, some of them are gonna block prostacyclin. And that's just kind of the midway point of this spectrum. And you were probably wondering, well, why is Brian wasting his time telling us about NSAIDs when we should be learning about the coagulation factor? Well, this is why. Because when you give NSAIDs, when you give NSAIDs, you can have side effects on different parts of the body, and some of those side effects can harm the patient fatally. For instance, when we give aspirin, like let's say the COX-1 inhibitor, that's a good one is aspirin, that's a poster boy for COX-1. When we give aspirin, we're going to inhibit the secretion of mucus in the stomach or in the small intestines. We're going to inhibit the creation of bicarbonate, and we're going to decrease the mucosal blood flow. So when we use too much aspirin, we run the risk of having peptic ulcers. We also run the risk of having GI bleeds. And so it's always recommended that you use the required dosage, the safe dosage. For instance, when you use aspirin, you want to use like 81 milligrams. You don't want to go and give somebody 500 milligrams or a gram of aspirin. That's not good, because a higher dosage will lead to a higher risk of having peptic ulcers or GI bleeds or just other gastric complications. Here we have a good example of the gastric system under the effect of a cyclooxygenase number 1 inhibitor. And you should know that prostaglandin E2 is going to cause vasodilation. So normally we have vasodilation. However, when we have the inhibition of cyclooxygenase by the use of aspirin, let's say, we're going to decrease the creation of prostaglandin E2. And if we decrease the creation of prostaglandin E2, we also decrease the vasodilation. So this is what you see here. We have vasoconstriction. Vasoconstriction decreases the amount of oxygen that is given to these cells. So these cells are now oxygen depleted. They are starved of oxygen. They can no longer receive enough oxygen and nutrients. In addition to this, normally we have mucus that has a lot of bicarbonate, and this bicarbonate protects the cells from being burned by the gastric acid. We decrease the mucus secretion, and now you have these cells that are exposed to the gastric acid. Here we have just these hydrogen ions, which are very acidic, and they're going to start breaking down the cells. So now these cells have no oxygen. They have a decrease in nutrients. They are also being attacked by the gastric acid. And if you keep doing this, if you keep pouring acid on these cells, you have these little pockets that form. And these are holes, and that's how you make ulcers. So when you're using aspirin, or when you're using too much aspirin for too long, let's say 500 milligrams for months and months and months, you significantly increase the risk of having an ulcer. And that's why we don't want to give too much aspirin to people, because that could increase the risk of ulcers. Again, 81 milligrams daily is fine. That's safe, and it is also effective for preventing the platelets from sticking together. So 81 milligrams is fine. You can also do 162 milligrams. That's also fine. But you don't want to do too much aspirin for too long. But 81 milligrams or 162 milligrams is fine. That should be all right. And you're probably wondering, well, what's H. pylori? Well, H. pylori is just a bacteria. It's called Helicobacter pylori, and it's a type of bacteria that can infect the gastrointestinal system and cause an increase in inflammation inside the stomach or in the intestines, and it's also going to increase the risk of having ulcers or gastric cancer. So this guy right here is a bad guy. He is bad. So this one increases cancer risk. It also increases ulcers and also increases GI pain. So a treatment plan for this guy, you would have to use something like Flagyl. If I could spell it right. Flagyl, that's a G, 500 milligrams, or you can use Augmentin. I've seen people use Augmentin. Like that for like 10 days. And you can also give like antacids like Protonix. And all that does is that it decreases the amount of acid that the stomach produces. You can also do something like omeprazole. And these guys right here are just 40 milligrams. But of course you want to talk to a physician about that. That's a separate video. That's like a separate topic. But for some reason in this picture they wanted to include it. I guess because it increases inflammation, it also increases your risk for ulcers. So if you have an H. pylori infection, you want to stop the usage of NSAIDs, you want to stop the usage of aspirin, because that is going to further increase the risk of having ulcers and bleeding. And of course, if you have any bleeding when you're using NSAIDs or aspirin or blood thinners, you want to immediately stop that bleeding and tell your doctor. Let's take a look on the effect on kidneys. So let's say that we're using something like Advil. So we're using Advil, that is ibuprofen. And as you know, ibuprofen, that's profen, can affect either COX-1 or COX-2. But when we look at the kidneys, we have to realize that there may be some damage if we overdo the ibuprofen. For instance, in a normal setting, prostaglandin E2 and prostaglandin I2, also known as prostacyclin, they are going to dilate the afferent arteriole. And that's just going to increase the GFR. That increases the amount of filtrate or the amount of urine that we produce. And therefore, we can excrete sodium and water. So this is a good thing. We normally want this to happen. However, when we inhibit PGE2 and PGI2 with these NSAIDs, we're going to retain water. We're going to retain salts, because this guy right here is going to be constricting. We're going to cause vasoconstriction when we block these prostaglandins. And therefore, you might have kidney injury. So if you use, let's exaggerate. If we use 2 grams of ibuprofen every day for a year, obviously you're going to have some kidney injury. You're going to have some water retention. It's not good for the body. You just want to use the safe amount of ibuprofen, and that is recommended by doctors. It's recommended by pharmacists. They have a set range for these medications. You don't want to overdo it. So let's take a look in detail on this effect on the kidneys. Here we have the process of filtration in the kidneys. So normally blood would enter into the afferent arteriole. Afferent just means entering. So we enter the glomerulus. Some of the blood is filtered and we form filtrate. So this is filtrate. And ultimately this filtrate is going to become urine. And then the blood exits from the glomerulus into the efferent arteriole. Efferent just means exiting. Normally, we have the dilation, we have the opening of the afferent arteriole. If we keep the afferent arteriole open, more blood can enter the glomerulus and more filtrate can be made. Also, at the same time, we have angiotensin II. And angiotensin II is going to be constricting vessels in the body. Specifically, when we talk about the efferent arteriole, it's going to be constricting the efferent arteriole. Why is that? Well, we want the constriction right here so that some blood is going to be building up in the glomerulus. And the more blood in the glomerulus, the more filtrate is being made. So slowly, the blood builds up as it leaves the efferent arteriole. However, when we use NSAIDs, let's say ibuprofen, which is both COX-1 and COX-2, that's ibuprofen, we're going to be inhibiting some vasodilators. We're going to be inhibiting the prostaglandin E2 and prostacyclin I2. We can also have this effect if we inhibit the cyclooxygenase number 2, for instance, through the uses of Celebrex. That's going to be strongly inhibiting cyclooxygenase number 2. But the reason why I mention it is because if you inhibit the creation of prostaglandins, then you inhibit this vasodilation. Therefore, you're going to have vasoconstriction, and therefore your glomerulus is not going to be filtering as much. So your filtration rate is going to decrease because there's not enough blood entering the afferent arteriole. Let's say, as an example, that a person was using Celebrex, or they were using a lot of ibuprofen, and at the same time they were using an ACE inhibitor, so angiotensin converting enzyme inhibitor. A good one would have to be lisinopril. So let's say that they're using lisinopril. That means that they're getting rid of angiotensin II. And that means that this vasoconstriction on the efferent arteriole is no longer there. So there is a vasodilation on the efferent arteriole. So there's even more blood leaving. So instead of the blood building up here and increasing the GFR, there is no buildup. All the blood leaves through the efferent arteriole since there's a wider vessel. So you have a little bit of blood right here because you're using Celebrex. You're using too much Celebrex, like let's say a gram of Celebrex a day. And then all that blood just leaves because there's a larger exiting on the efferent arteriole. So that leads to a reduced GFR. And ultimately, if you keep doing this over months and months and years, you're going to have kidney damage, and that's not good. Now, an important thing to notice is that with aspirin, if you use 81 milligrams, that's the magic number, 81 milligrams is safe. It's not going to do harm to the kidneys as long as you stay within a healthy range of 81 milligrams or 162 milligrams. So people with kidney disease, you can still give aspirin as a way to prevent the coagulation of blood, and that's not going to hurt them. You don't want to overdo it on the NSAIDs, you don't want to overdo it on the aspirin, because then you're going to have GI problems and you're also going to have the complications in the kidneys. But using the safe recommended dosages for these NSAIDs is good. You don't want to use ibuprofen every day. You want to use it like Monday, Wednesday, or Friday, and just kind of use the bare minimum of ibuprofen because you don't want to cause harm to the kidneys. Finally, let's talk about the cardiovascular effects of NSAIDs. When we use NSAIDs, let's say that we use an NSAID that can block cyclooxygenase number 1 and number 2, well, we're going to have some complications if we use too much of it. For instance, for prostacyclin, normally the vessels are like this. Vessels are like that, and the platelets are just kind of floating around. And the reason why we have this large opening, these dilation, is because we're using prostacyclin. So we're using prostaglandin I2, also known as prostacyclin. However, if we get rid of prostacyclin, well, guess what? We're going to have some vasoconstriction. We have some vasoconstriction right there. And I'm exaggerating the narrowness, but now you have a lot of platelets coming together. And that's not good. But luckily, these platelets are not sticking together. However, if you use a drug that inhibits the formation of PGI2 but allows the formation of thromboxane, well, now you have a decrease of PGI2, but you have an increase of thromboxane. And thromboxane is going to make these platelets stick together. So now we have the stickiness of the platelets occurring. And we're just going to make these little green marks to represent that they're sticky. Well, guess what? We just formed a blood clot, and this blood clot can go to the heart, or it can go into the lungs, or it can go into the brain and cause a stroke or an embolism, and it can even kill the patient. So we have to be very careful when we're giving NSAIDs or medications. For instance, if I give Celebrex and I give too much Celebrex, we have the inhibition of cyclooxygenase number 2. Therefore, we're going to inhibit a lot of this prostacyclin. However, cyclooxygenase number 2 is not going to inhibit as much thromboxane. So we have this decrease of prostacyclin, but we have an increase in thromboxane, and therefore we have the narrowness of the vessels, but an increase of the platelet aggregation and an increase in the platelet stickiness. And that causes strokes or an embolism, and it's just bad. So that's what they're saying over here. If we inhibit cyclooxygenase number 2 more than the cyclooxygenase number 1, we have an increase for strokes and we have an increase for heart attacks. And we're going to look at a picture that just summarizes what I just said. So now you can notice that prostacyclin, PGI2, is going to keep this vessel wall dilated. However, if we use a very strong cyclooxygenase number 2 inhibitor like Celebrex, well, guess what? We're going to decrease the amount of PGI2 that is being created. And if we decrease the amount of PGI2, we decrease the dilation of the vessel walls. Therefore, all of these platelets are going to be congregating. They're going to be collecting right here. Now, notice that for the cyclooxygenase number 2 inhibitor, we decrease prostacyclin. However, we do not decrease significantly the amount of thromboxane. So now that we have a lot of thromboxane is going to cause these platelets to stick together, and it causes blood clots, which can go into the heart or to the brain and cause a heart attack or a stroke. And when we use aspirin, aspirin is mainly going to be blocking cyclooxygenase number 1, and therefore we're going to decrease the amount of thromboxane right there. So if we don't have thromboxane, we don't have as much platelets sticking together, and that is very effective. So aspirin, again, 81 milligrams of aspirin a day is enough to prevent an excess amount of clotting, and it lasts for the lifetime of the platelets. So platelets are typically recycled, or they're remade inside the body every 10 days. So this little platelet right here, let's say that this is the platelet and it was affected by aspirin, so we're going to make this little purple or pink. This guy right here can never bind to another platelet again. However, in 10 days, this platelet is going to be remade, and it no longer has the effect of aspirin. So now it can bind to other platelets again. So it lasts for the lifetime of the platelet, but the lifetime of platelets inside the human body, on average, it's about 10 days. And so that's what this picture is saying. If you block the cyclooxygenase number 2 with a very strong drug like Celebrex, you're going to decrease the amount of prostacyclin. That decreases the dilation of the vessel. The vessel squeezes together the platelets, and now you have this excess amount of thromboxane because it was not affected by the cyclooxygenase inhibition, and therefore these platelets are going to stick together and cause clots. So we have to kind of read a label for the medications, and I'm going to show you a black box warning. So when I'm talking about black boxes, so black box warning, when you're studying pharmacology or drugs, always look at the black box warnings, because black boxes are important. They say, hey, you shouldn't give it to this patient because this patient will pass away. This patient will die if you give it to this person. So black box warnings are very important. You don't want to ignore them because they can save lives. So here's the black box warning for NSAIDs. So take your time and read this black box warning so that you can protect your patients or whomever you care about. Hopefully now you understand the importance of these cyclooxygenases and their inhibition. So for aspirin, we're going to strongly inhibit cyclooxygenase number 1, and that's going to strongly decrease the formation of thromboxane. And if we decrease thromboxane, you decrease the amount of platelets that stick together. And now, let's watch a video by Bayer, and we're going to learn about aspirin. And again, Bayer is a large manufacturer for aspirin, and they made this really nice video that talks about the coagulation factor.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways: the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor Xa in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
So you're probably wondering what these little A factors are. So for instance, factor 10 will become factor 10A. Well, factor 10A, that just means activated, so activated. And therefore, this factor 10 is going to activate other factors. That's all the A's stand for. So we have factor 12 becomes factor 12A. That means activated factor 12, Hageman, Detective Hageman, F12. Factor 11 becomes factor 11A. So just the activated form of this factor, and you don't have to worry about it. But now when you see pictures that look complicated, you can actually understand it because look, you have the cheat codes. Just memorize these numbers. 3 plus 7 is 10, 10 divided by 2 is 5, and then we have 2 and 1. That's the common pathway. Then 12, 11, 9, 8, 10, 5, 2, 1. Also pretty common, pretty simple. So I hope that I helped you out in learning the anticoagulation cascade. It was really fun. I liked making this video. It's really chill. But just know that you are awesome. That you are awesome and cool. And I love you very much. So thank you so much for watching this video and spending time with me. Alright, take care, and I love you. Bye.